we provide continuity of care. So we're providing one named nurse for that patient, and GPs like to have continuity. They like to see the same person, and so that it's not just the patients and their families, but also the other healthcare providers that we're working alongside. We've done a lot of engagement with the PCT, with the acute, with the community, other services, with social services, to sort of put their mind at rest that we're not there to take their jobs, that we're there to complement what they do, to work in partnership with them. District nurses are really stretched, and they can't see all patients who haven't got a nursing need, and we're there to, as their eyes and ears, to monitor those patients. We do a step up and a step down process with the community matrons and with the 3 hospices within Birmingham that we work with as well. As I said, our notes, we do real-time reporting, so on a monthly basis we go back to our commissioner, we can tell them exactly how many patients we've seen for that month, how many patients have made their own choices and have expressed a wish of where they want to die, how many patients out of those deaths have died in their preferred place of care, and if not, why haven't we been able to achieve that? So that's very important for commissioners to know that we can provide that information. Now, being a nurse, I'm not very good at sums, so you'll just have to take my word for this. If I can't count it on 10 fingers, I'm not very good. This was our savings in our first 5 months of our service. And our achievements, which I will go through very, very quickly, 98% of our calls are answered within 30 seconds from our care bureau. We have a rapid response service, so one of our team is on call 24/7, 365 days a year to either triage calls or to go out and see patients if we need to do that. We've exceeded our referral numbers by 12% and obviously exceeded our target savings, and only 4 out of our 179 patients in the first year of our service was readmitted. This obviously is one of our patients. Unfortunately, this lady died at Christmas, but she was really keen that she wanted her face to be on our leaflets, that, you know, we do use patients. We are very patient focused, and that patient feedback is really important. All our patients get a patient questionnaire. We didn't feel that it was appropriate to send them out to bereaved relatives. We wanted to know what the patients felt about our service when they were actually getting the service. Okay, I did have a film to show you, but unfortunately I've run out of time, so thank you very much.
Thank you very much, Karen. Again, we're going to have 5 minutes of questions, and whilst we're doing those questions, I'll invite Annie Laverty to come down and we'll just make sure we're set up. I'm sorry about your film. Obviously, it'll be available on your... people can have a look at it over the lunch. Okay, questions. Put your hands up really fast this time.
It's obviously a wonderful service. How did you get funded, and is it ongoing funding, or do you have to justify yourselves with continuing savings to keep your funding?
In the summer of 2009, Birmingham East and North, who we're commissioned by, were looking at their strategy and end of life, and so they went out to patients, families, other health providers to ask where the gaps were. The gaps were 24/7 single point of access, a named coordinator, signposting, and those were the gaps that we came together and worked in partnership to fill. And so that's what we've done. We're trying to plug the gaps where the service was failing. We had 12 months test and learn, and we've now had that contract extended to 2013, and we are now in the process of having talks with the CCG to extend our service to the whole of Birmingham and beyond. We have a service in Bristol which is very much the same as this, and we are also in talks with other areas around the country about providing a same or similar service, a flexible service using this service model.
Sorry, just to clarify this funding issue. First of all, thank you and congratulations getting this far. From the funding point of view, are you saying therefore that this is more or less a bespoke service that you would discuss with what you provide for one trust or one hospital, maybe different
I mean,
to
obviously,
what you would...
we would be looking at the same sort of model, a care coordination, but it would be very flexible to the area. It could be that there may be some different skill mix. All the team are registered nurses with skills in advanced communication and have gone through training. But obviously, if a cluster group were looking at a different skill mix, then we would use the same model and it would be very bespoke to what you wanted, using our care bureau as backup as well.
Oh, sorry, yes, it's me. I've just been given the microphone. Yeah, I know you said you didn't want to talk about the sums, but I would love to be able to put figures up like that myself. So is there somewhere we could access the methodology of how you actually did it, or how somebody actually did it?
I can give you I can give you my details, and whatever you want to know, I can get some information for you. Obviously, I'm the operational side, and I don't go into the sums of it.
Yes, indeed.
We have an NHS projects department and a service design team that work alongside us who go through all the financial side of things.
Excellent, thank you.
Okay.